Dr. Brannon, welcome. The floor is yours.
Obrigado. Thank you very much. I'm honored here to speak on pellets. I'm an OBGYN by training. I was a professor at the University of North Carolina, Chapel Hill, OBGYN and pelvic surgery years ago. I was exposed to pellets, and I want to tell you my story when I heard about pellets for the first time, because I was a big skeptic on something I did not know about. I met this friend of mine, an acquaintance, and he was sitting, moving around in his chair, moving side to side, and I asked him, what's going on in your back? He said, I got this thing called testosterone pellets. Have you heard about it? I said, no, I have not. This was in 2010. And I said, I know it's going to cause cancer, though. And he challenged me to study it, because I just thought I knew what I knew. And I started studying. I took 2 years studying pellets, where they came from, how long they've been going on. And I realized that these are, I don't want to say a miracle, but it's what our body runs on. And it's very important to understand that the structure of a chemical, as you guys all know, being doctors, is truly important. Bioidentical hormone therapy is not a marketing tool. It's exactly the structure your body makes. The Mayo Clinic in the United States says bioidentical means body recognized as same. And what people understand is when pharma makes drugs in the United States, they cannot own an organic compound. They have to modify it or change it or isolate it or find one, and then they own the patent for 17 years. So no pharmacy company can own an organic molecule. And the body is extremely smart in that if it has a molecule that it knows, it makes it itself, it knows how to utilize it, metabolize it, eliminate it. Because most of the side effects occur from structures the body does not recognize. The liver is a great filter. There are things that can happen that cause blood clots or cause other side effects. So I was down this whole path about, so who used pellets? What was going on about them? And some of the slides I have are going to be a lot of review, obviously. But what I found out, the bottom line about this is the ranges of hormone levels have changed dramatically. And as the hormone levels have went down, chronic disease have went up. And that's what's very frustrating as an OBGYN, is that dealing with women in perimenopausal, menopausal age, it's the symptoms cause the problem, the hot flashes, the sweats, but it's so much more deeper than this. It has to do when it's like when your body's having these symptoms, it's like your dashboard in your car having these red lights go off. Those are warning signs. There's a paper from Harvard 3 years ago that says a woman has hot flashes has a 200% increase in cardiovascular disease, heart attacks. So you have to understand, I think it's very important to understand what testosterone, what estrogen, and what progesterone do, because there are benefits outside of libido and muscle. It actually has a lot more bearing on other functions. And at the end of the slides, I have some disease processes we'll go through. But the big thing we hear about, we hear like these are new, or it's, there's not enough studies on them. The first time testosterone was isolated was in 1931. The first study ever done on testosterone therapy replacement was in 1935 in Germany on women with hysterectomies. It wasn't men, it was in women first. Women, as gynecologists, I didn't even know, but women have 50 times more testosterone than estrogen. That's why I hate the phrase male hormone and female. They're human hormones. The first study in men was in 1937. And the papers were done. What was the technique? The very first technique ever used in hormone replacement therapy was pellets. They dried up, compressed. I'm not a compound pharmacist, I don't know how it's actually made, but it's actually made these small pellets, and the pellets were placed subcutaneously. And the reason why the route is so important is because it will secrete it at a steady state. I'm going to draw some pictures later on that, on why the steady state is so important. So again, this is not new. The esters did not happen until 1939 and 1941, and then the creams later on in the 60s. There are 3 categories of anabolic steroids plus the bioidentical. So the question I had when I started doing this is, in my mind I started thinking of low testosterone levels as diabetes. Now, this is my comparison. We have 2 types of diabetics. We have a type 1 diabetic who does not produce insulin. We have a type 2 diabetic who has too much insulin, but the receptors are not sensitive enough. You would never tell the type 1 diabetic, eat right, lower carbohydrates first. You'd give them the insulin first. That's life-saving. I believe in androgen deficiency and hormone deficiency is the same thing, because the lower your hormone levels are, chronic disease increase. Diabetes, cardiovascular events, osteoporosis, Alzheimer's, dementia, those are all correlated to lower levels of sex hormones. And I'll go over that in a moment on that. And I do love questions. I speak way too fast, so the more questions you have, the better it'll be for me. So please, any questions, just scream out. So that's the whole process here. I'll start with this. Okay. This is all basic stuff. I understand you have the hypothalamus, the antipituitary. There are 6 hormones made in the antipituitary that run the body. Some more pictures of that. It's important to know that there's 6 hormones there, 2 made by the posterior hypothalamus, which actually are extensions of the neurons, but this one controls the body. And it's interesting too, where the hypothalamus and antipituitary sits in the brain, the optic chiasma is actually bone. And in head trauma, in TBI, in head trauma, the first 2 hormones that are affected are gonadotropin, the growth hormone, because they're the further away from the blood supply. So anatomy has a problem with TBI. It's a little side note. I have some stuff here. So estrogen. We'll go through that first. I want to draw this picture. Okay, in men and women, you can make testosterone first. That converts to estradiol. Estradiol has 3 ways to leave our body, 3 pathways. We have 2 dehydrogenases and 16. What's important to understand is that estrogen itself has 3 receptors. You have 2 receptors. You have an alpha and a beta. Alpha is more for growth. Beta actually negates the alpha. E1 is a 5-to-1 alpha. E2 is neutral. E3 is 1-to-3. It's a negative growth. That's the thing about the centers. So we'll scratch that out. So during this time here, you think about it, in a woman's life, she's born, she passes away, menopause. What hormone dominates when she's younger? E2. What dominates when you're older? E1. Where's most of breast cancer? Where's most of the cardiovascular disease? Where's dementia? It's all here. Because you think about it, this dominates with an alpha, which is potentially a proliferation of cells. Very important. So this, in the back of my mind, this is what I'm thinking about when I'm doing this. It's just not give a pill and hope something goes on. This body is very complex, but if you give it the right substrates, it knows what to do at the proper levels. And that to me is the most important thing about this idea of how pellets work. Again, I'm no artist, okay? We talked about ranges. Let's see if I have that here. I can pop it in. All right, this is just pure biochemistry, how it works. We talked about the testosterone converting to estradiol. You know how that works there. There's 2 types of receptors for sex hormones. There's the genomic and the non-genomic. We used to talk years ago, it's just genomic, where it actually affects transcription in the DNA. We now know there's receptors on the outside of the membranes as well, primarily in the brain. And that's why hormones have mood changes. They work in the brain faster. And estrogen, estradiol, is actually an active metabolite of testosterone. Testosterone is more abundant. When you look at the values, in America, we use picograms to measure estradiol, and we use nanograms to measure testosterone. Nanograms are 1,000 times bigger. So when you look at the chart of the labs, realize that's how much more testosterone we have. But this is just basic, biochemistry. Progesterone has functions mainly in the woman, but sometimes in the man as well. We'll go over that in detail too. This is what I want to get to. This is why I believe it's really important to understand ranges. A range is just a population growth. They get 10,000 people in a study, they measure that population, and they get a median, a standard deviation side, 80% of people fall to that curve, all right? That's how they get it. What's very interesting, in the United States, LabCorp says a man is 264 to 916. Okay, that's what a man is today. Funny thing, 7 years ago, June 30th, 2017, it was 348 to 1197. I'm 64 years old. When I was in school, the range was roughly 900 to 1400. So remember, we're doctors. We're not robots. We have to ask questions. This is an art. The question we should ask ourselves is, why is it lower? That's the most important thing, not what the range is. Women today, LabCorp says a woman is 3 to 41. 7 years ago, it was 5 to 50. When I was in school, it was 90 to 200, 250. So again, the question is why is it changing? I think that's the crux. I believe that's the reason why we have chronic disease. In 1960s, in America, about 3 to 7% of Americans had chronic disease. Now it's up to 75% of chronic disease. So what's going on in this biochemistry that's affected us to be chronically ill is the question I want to ask myself. And the question I have, if we run at this level for a man or this level for a female, will we decrease chronic disease? And I got charts at the end to show you some studies. I believe the answer is yes. But has anybody asked, like when you get a lab result from anybody, where these levels come from? I mean, if you get this lab, if you're literally at work, and this is June 30th of 2017, that's your lab value. The very next day, LabCorp changed to that. 2017. Very next day, 24 hours later. Shouldn't that put antennas up and ask us what's going on? And I believe that really got me going on that. So the question is, how does this happen? Again, as I said, testosterone becomes estradiol, and there's 3 pathways to limit the body. And this exposure is very important for that. But there's these neuroendocrine disruptors. I think I have a chart of this. Okay, this has to go to decline. So this decline of testosterone going down over years, year after year. The average testosterone dropped nearly 1% since 1970s. The average male is about half that testosterone was 40 years ago. Sperm count will correlate with testosterone. Testosterone matures sperm. 1970 to 2002, we're losing this. This is a North America and Western Europe study. It's decreased sperm count by 1% per year. By 2002, it's increasing 2% per year. So my population has doubled the sperm count from 35-year-old and over. So that's very important. Again, I think we have to ask what's going on. MIT and Hebrew University said by 2050, men will be infertile in Western Europe and the United States. These are big things, but again, it correlates with our count of testosterone, with our sperm count going correlate with that. There's our sperm count. All right. So why? Endocrine disruptors. Just common activity. We have toys, plastics, food packaging, all these kind of things here. It's area with. But what happens is this with the chronic disease that occur. But back to this. The number one is phthalates. These are plasticizers. They have an interesting function. They decrease the production of testosterone. They increase the activity of aromatase, therefore increasing estradiol. And they seem to push down these pathways, which are more alphas. This is a beta. These are things that happened in the 1980s. I'll go over some data earlier than that. But that's what's happening when your levels decrease. Diabetes, breast cancer, mood swings, muscle, inflammation, obesity. At the core of it, I have 10 functions from Dr. Richard's book down the line here, I'll show in a moment, showing the 10 functions of testosterone. When they're applied, you can see how chronic disease occurred when these numbers are not functioning. We're running now at a population of about 20% of, say, 1930s, 1940s. Any questions at all? I know a lot of it is repeating because you guys all understand all this stuff, but it's just frustrating not to attack it that way. Yeah, I got that. All right. We already had aromatase, something like that. So optimizing the hormones. What would happen with optimizing? You decrease heart attack risk, diabetes risk, cancer, Alzheimer's, dementia, depression, energy, libido, improved mental clarity and protection. So why do I use pellets and why do I use bioidentical? book called Sex Hormones and Neurodegenerative Disease out of Belgium. It came out about 2 years ago. It divided testosterone into 4 categories. You have BHRT, which is the structure your body makes. You have 3 other categories. You have the ester, cyprinate, propane, ethernate, the first ones that were invented. You have 19-nortestosterone, which is a testosterone base that's manipulated to carbon-19. These are both injections. And then you have a 17-alkylation. That 17-alkylation allows it to be absorbed orally. It's a long carbon molecule, allows the liver not to tear it all up. And decadase is one of the biggest ones. D-ball's another name for those. All those work. They're anabolic and androgenic. But there are side effects to them. Slight increase in blood pressure, slight increase in blood clots, and the biggest one about all 3 of these categories is small risk, but increases morale apoptosis. Brain cells die off faster, and they're correlated maybe with a higher incidence of Alzheimer's. What's interesting, the BHRT, the one our body makes, lowers blood pressure, no blood clots, and it actually increases neuroplasticity. It actually makes more brain cells. And it makes the brain cells actually get closer to the synaplasticity, makes does the synapse actually a tighter junction. So that's why they're not all the same. You cannot throw them together. Another example is in America we list all progestins, either synthetically made or natural progesterone, as the same. Natural progesterones decrease breast cancer, decrease dementia, decrease heart attacks. The synthetic brand birth control pills increase breast cancer 30%. Provera increases breast cancer by 69%. I've written 2 books on that. They're back here somewhere. One called The Hormone Handbook, one called Restore. Restore has I have 497 references, 82 on breast cancer alone. The data is out there. More hands. So this is the thing I really want to get to. This is the best I see with Dr. Mark Richards' book. It's called Nobody Wants You Healthy. And he breaks down 10 of the most common things that testosterone does. Reverses and prevents diabetes. I'll have papers at the end to show all the papers and studies that back these things up. It actually stimulates IGF-1 to be more receptive, to make the insulin receptor more sensitive. Decreases circulating inflammation. It's very interesting. The interleukin-1 and TNF is decreased by testosterone. Those are the pro-inflammatory cytokines. And interleukin-10 it actually increases that, which is the anti-inflammation cytokine. It increases other factors of anti-inflammation. It decreases vascular inflammation, so atherosclerosis. It fosters healing better of the scar tissue of the plaque. It promotes blood vessel dilation by increasing nitrous oxide synthase, which is very important. That works at the endothelial level. The endothelium is not a barrier, it's an active barrier that's that's where things happen with atherosclerosis, kidney disease, neurodegenerative disease, when the endothelium is damaged. Reduces the risk of abdominal clotting, decreases cholesterol and decreases abdominal body fat, gets rid of brown body fat, increases cardiac blood flow and heart function with disease. And the big one, and the last one is, the major thing, it's one of the #1 things to increase CoQ10 in the mitochondria, and one of the highest antioxidant burdens it does is when it increases. So testosterone has those functions. And if you apply those to disease processes, you can actually see the benefit. Still no questions. I think I have it here.
Mulheres com score de cálcio aumentado, já com a teromatose estabelecida, ainda tem um benefício na prescrição da testosterona sem riscos, melhorando esse quadro?
Okay, what she's talking us about is, do not give hormone therapy to women over the age of 60 because of built-in calcium, atherosclerosis. Am I correct? Okay.
Risco cardiovascular aumentado. Risco cardiovascular.
Higher cardiovascular risk.
Risco cardiovascular
Higher
aumentado.
cardiovascular risk.
Mulher que tem risco cardiovascular aumentado.
She's asking if a woman with higher cardiovascular risk can use testosterone therapy?
Yes, I got a chart on that coming up. I have a whole chart on that. See if I have that one, if I get right to it, right? See, you brought it up. How did I go backwards? I see. Okay, where's my chart? Oh my gosh. How can you go backwards? So women, do I have the chart on that? Can I go backwards here? They didn't put it in. In my book, Restore, I have a section on that by Dr. Hodes from USC in Los Angeles. Women, 64% to 51%, have a higher initial death rate from a heart attack. Women have more heart attacks and more recurrence of heart attacks than men do over the age of 50. We think it's a man's disease. It's actually a woman's disease because estradiol is protective of the endothelium. But you talk about the calcium score. They recommend if you don't start hormones before the age of 60, don't start them afterwards because there's a slight increase in an MI. It's extremely small for the first 6 months. After that, it's protective. It's protective. All right, that's Dr. Hodes' paper. There's a book called Estrogen Matters out of USC as well. Dr. Hodes as well writes that, showing the data on that. I don't know, I had a chart of that. It's in my book, it's in Restore. Okay. Any other questions before we get down? Let's do a couple. Let's do this.
Greg.
God, thank you for speaking English.
So in this case, in this woman, you would use like a lower dose of testosterone the first 6 months, and then you make it bigger. Or...
No, okay, good. Let's go over the whole study. From 1935, the first paper ever done, to 2002, the famous WHI paper, right? We all know the WHI paper, right? You guys remember that came out? July of that year. There was no papers in 77 years that hormones are bad for women. None. That paper came out and said, we have a problem. Hormones cause cancer. What did they do in that study? They had 2 arms. They had Premarin, and they had Premarin plus Provera. Premarin is E1 from horses. It's not E2, and it's a horse urine. It's a non-human hormone. The other arm was Provera, same thing, progesterone plus medroxyprogesterone, which is a progestin. This arm increased breast cancer 24%. So the next day in the news, it was hormones cause cancer. This arm had no increase in breast cancer, none. So first off, you got to ask yourself is, that's not estradiol, that's not testosterone, and the route was oral. And by the way, this stimulates alpha, not beta. Terrible study. Johns Hopkins went back 15 years later and looked at the same paper. How these women did. They found the women with breast cancer living longer, less dementia and cardiovascular disease. They had breast cancer, but they had less other things. So a guy named Firinero in France did a study in 2005 and 2007. 134,000 women. He gave them estradiol pellet, progesterone by mouth, estradiol pellet, and Provera by mouth. This arm decreased breast cancer 10%. It mimicked a youthful woman. This arm increased breast cancer 69%. It's the Provera. And I know Dr. Glazer spoke here last year. She's in Ohio, a breast surgeon. When she adds testosterone pellets to that, she has a decrease between 40 and 60% of breast cancer. Because there's more testosterone receptors in breast tissue than estrogen receptors, and it's anti-proliferative and pro-apoptosis. It kills cells off. She published a 10-year study showing this, and no major journal published.
She's going to make a publication in 15 years.
What?
Last year was here, in the
Yeah.
last year.
Yeah, last year, yeah. Dr. Morgenthau, I'm going to quote him too.
Yeah, of course.
Yeah, Dr. Morgenthau, you have some big wheels. I'm not a big wheel. Those are big wheels.
So she's going to have a publication. It's near to be ready.
Oh, yeah, I read it. I talked to the summer.
Seriously? 15 years.
And a side note, Dr. Gino Torre, who started Soda Palais, He trained me in February of 12. He published his own study, 10,000 women years, 10,000. He has one breast cancer.
Who?
Dr. Tatur, the guy who started Soda Play. He's passed away. He has his own practice. He published a paper. And very interesting, he did that, just giving estrogen pills and testosterone, not knowing about alpha B receptors at the time. That was not recognized at the time. See, estradiol is different than estrone. And again, Premarin is not a human hormone. That's really important. But even the book called Estrogen Matters, even the synthetic arm does better than not treat at all. And the thing about scaring women not to go on it because over the age of 60 you're not stopping. Dr. Lobo, Columbia, trained me. He's worried about the first 6 months because you may displace some of the plaque being built up. But after that first 6 months, it decreases. It decreases. So that's what I mean. Here again. I'm not joking. I'm not that smart. Do you want the biochemistry of an 18-year-old or an 80-year-old? And we're living now we're living like 80-year-olds now. So if we you would never tell a man or woman who's a type 1 diabetic, you're too old for insulin. You would never say that. So the most abundant active hormones in the human body is not insulin, it's not cortisol, it's not DHEA, it's testosterone. So why would you live at 20% of max? It makes zero sense to me. I got some studies here. I don't know if they loaded it up. Let me see. Okay, the prostate cancer. So in 1941, Dr. Huggins and Hodges wrote a famous paper, the urologist quote, that TRT increases prostate cancer. Okay, world famous. Dr. Huggins won the Nobel Prize in 1967. How many men were in that study? And oh, by the way, he had no testicles. He was castrated. And that's what everybody quotes. And you had Martha Morgenthau here last year. His book, Testosterone of Life, chapter 7, chapter 9, go through this clearly. So he did a study. It was only 13 men that he biopsied himself, gave them pellets, 2.5 years later, rebiopsied them. 54% had no cancer, 40% had no change. He also has a paper, prostate cancer with and without. The with pellets have less dementia and cardiovascular disease. If you read the beginning of his book, he said, he quotes like these 50 things. If you had a drug that did these things, what would you sell it for? And it's testosterone. It's all the 10 functions we have in that will help every chronic disease. Gosh, they don't have my shirt. I'm sorry, they gave Marcos, they gave me the old, these are not the final slides. I got a slide. The prostate gland and the breast tissue are almost exactly the same type of cell in men and women. And think about it. If testosterone caused prostate cancer to grow, how many 8-year-olds you know have prostate cancer? Okay? Higher testosterone, I'll get back to that. Every cell in the body has a receptor for testosterone. Every cell has different needs of estrogen in their body. So the aromatase is an intracellular enzyme that will depend upon how much estradiol the cell needs. Bone needs a lot, brain needs a lot, breast tissue needs less, so certain tissue have certain things. So testosterone being higher in a male suppresses the estradiol being met, and as you age, you're not losing testosterone as you age. The longer you live, the more you're exposed to the neuroendocrine disruptors. And that's why you lose testosterone. Not because you're older, it's exposure to phthalates, to atrazine, to plastics. That's why you're low. I've done about 100,000 placements. I have 9 offices in the Southeast United States. We're starting to collect the data now because my 25-year-old men who come to me, they average out 180 to 250. Just the opposite of what you think, an older man. I've had 9 people over 900 in the first visit, and 8 of those 9 men were over the age of 80. They were just here because their boys were here. It was a different generation. So I'm collecting that data now to show the ranges has changed based upon the exposure in the womb. And Dr. Morgenthau has a great section in his book on that, showing the study that WHA did that shows phthalates in 34% of placentas they studied at a higher level than the body can tolerate. Gosh, I wish I had a chart.
We're seeing if we can get it.
Okay, I have it back in my thing. Okay, because I have a bunch of studies I want to go over that. They're not in this one, but I have diabetes studies. There's a study in Germany, 11,000 men over a 10-year period with diabetics giving long-acting testosterone, and they found a 34% remission of diabetes. And when stopping the testosterone, 100% recurrence of that within 6 weeks. Gosh, I need that chart. I got like 10 papers I want to show you guys. Any questions? My whole talk is on a slide, so if I can get that slide on, I'll come together there. All right, so what else I have here? Okay, that's what I was talking about there. Okay, men who receive testosterone deficiency, 50% lower death rate. This is a great one. So this was done in Kaiser. They looked at 1,000 vets over the age of 40, and they found that the chance of dying was double those with lower numbers. Now this also is important. You look historically, a man under 300 is considered extremely low. A man under 500 is considered low. Again, that's the range we have today. A female, 300 in a male equals 25 in a female. 500 in a male equals 37 in a female. So, and then when you get your labs and you look at your lab values, in my office, my lab values are there's a study done in 1940s on Army recruits, so men in Army, they're recruiting for the Army. That was 914, like I said. And I used that lab, and I used the lab for women between 70 and 250. But there's a company called yes. Oh, great. It's a new one. All right, breast cancer. Okay, good. Breast cancer has been in treatment since 1940s. You talked about that. That's a 10-year study. Dr. Glazer's paper. Okay. Prostate cancer, Huggins and Hodges. All right. Now this is it. This is what I love. Decades later, administrated 10 pellets, no cancer progression. He's also stated there's no evidence, nor has there been any evidence that testosterone therapy increases prostate cancer or BPH. All right, here's a bunch of papers to go through. So no local prostate, we did that one. Cardiovascular disease. 1,000 males, this age here, double the rate, and then this is a Kaiser Permanente study, same thing. This was about a 7-year study showing that the low testosterone levels given men at the form of testosterone therapy had a 50% adverse effect on testosterone treatment. So again, these are cardiovascular events were decreased by half when their levels were optimized. And interesting, that was just over the age, just the number over 450. That was the cutoff, was 450. There was another study done in the VA, I don't have it on here. They looked at 70,000 men over the age of 50. And if their level was under 350, compared to the other group over 540, the men at 350 had an 80% higher chance of a heart attack, 40% of death versus over 540. That's why it's important to look at those numbers. But I want to show you this one chart I have. Okay, well that's European study. All right. Oh, this is the thing. We hear testosterone causes cardiovascular events. This review paper right here is fantastic, done by Dr. Morgenthau. He looked at papers from 1940 to 2014. 4 papers questioned the benefit of testosterone. The other 20,000 said only benefits. I want to show you how you feel. Okay, this is the heart attack. It's out of my book. I have this in my book called Restore. This shows you think about women not being more important in cardiovascular disease. Number 1 death killer in women is cardiovascular disease. Not the questions. I know I talk so fast, I'm so sorry. All right. Diabetes. Diabetes is, look how much money it costs. This is America. It's preventable. Back to why. Back to the 10 things, the first function. It sensitizes IGF-1, which sensitizes insulin for it to work. study published this study, you guys read, 34%, this is what I talked about before. 34%, just at levels of 450. What if you're optimized at 1200? Another great study out of Australia. Look at the data. So the thing is, over and over and over again. Dr. Mark Richards, again, in his book, Nobody Wants You Healthy, he was a White House physician for President Obama. And he estimates, this is before COVID in America, America spends $2 trillion a year on health care. $2 trillion. 90% of that is chronic health care. As I said, in 1960, 3% of Americans had chronic diseases. Now it's in the 70s. He estimates that everybody's optimized, we can decrease the cost, healthcare costs by $1 trillion. All right, osteoporosis, that's obviously a classic here. So, so osteoporosis, do you want to wait till you have osteoporosis, or do you treat it beforehand? I'll give you an example. Osteoporosis in the United States is number 9 leading cause of death in women. They don't fall down and break their hip. They break their hip and fall down. All right? Men and women lose 0.5% of bone every year, starting at age of 40. Women accelerate after menopause, they lose 5% per year. At the age of 70, 70% of women have broken vertebrae. And the bisphosphates make a hard brittle bone. After 5 years, there's more broken jaws and broken hips in women who are on bisphosphates. When you take testosterone and progesterone make bone, estrogen slows down reabsorption. So if you stay on a pellet, this paper was published in 1979 by the American Journal of OBGYN, that pellets increase bone production 8.3% per year. You eliminate osteoporosis by being on pellets. All right? I wish I stayed Portuguese. This is a big one. The Ziegler-Lin test, they did a scale. This is a subjective test. How do you feel? And women doing pellets, it was roughly 100% of women felt better. They did the same study with about 10,000 men and gave them long-acting testosterone. They gave injections. They had a 22% patients felt better. They converted them to pellets and a virtually 100% benefit. Why is that important? This is really important. I know I repeat this all the time. When this is stabilized, the aromatase is stabilized, the estrogen is stabilized. If this is variable, this enzyme is never in sync with this. The so-called roid rage is not testosterone, it's the variability of the estrogen. And all of the non-human anabolic steroids have high variability of their estradiol and usually an alpha receptor stimulation of the brain. This is the pellet. Peaks in 2 days and goes down like this over 6 months. The pellet, a 200 milligram pellet releases 1.3 milligrams per day per pellet, roughly 0.6% per day. Cyprinate is a half-life of 3 days. Undecanate is the 21-day half-life. That's the longest acting ester you can get. When that's like that, that can never be in sync. Nothing mimics the testicle or the ovary other than a pellet, period. I know you guys have been here a long, long day, I understand. Any other questions? So my whole thing at the end of this is this. Let's attack aging as a disease. If you attack it as a disease, you're trying to eliminate things that cause the age faster. I mean, we're going to die of cardiovascular disease, we're going to die of neurodegenerative diseases, we're going to die of those things. This is push from the 60s to the 90s. Just push as far as we can. That's the bottom line. That's the whole idea of the pellets. And again, the big answer to me is, to get back to my example, if you wanted to know an optimal blood sugar level, and you have a million people in your study, and you have a million people donate blood for the optimal blood sugar, but all of them are diabetic, the results are null and void. It's irrelevant. You need a placebo group of healthy people. The problem is we don't have healthy people anymore. So the only thing that gives us healthy people for a range is history. Go back where there's less plastics, less atrazine, less of these neuroendocrine disruptors in the environment. We have the data. Go back to those charts and then correlate how much cardiovascular disease, how much diabetes we had back then. There's a book called The 100-Year Lie about the FDA. In 1913, less than 1% of Americans had diabetes or cancer. So what happened is the question. And I believe, I'm not against growth in industry. I think it's great, but the problem is we're not rats or flies that we can multiply in days to see what happens in generations. We got to watch generations like DES or thalidomide. You can't do anything. Those medications were used for good causes, decrease miscarriages, but you don't know the side effects until things happen. So I want to get back to the actual structure our body makes, put them at optimal youthful levels, and then see how chronic disease goes. I believe there's enough data to support that. Again, in my book, Restore, I got, I think, 397 references and then 82 on breast cancer alone. So I think the data's out there. Dr. Mark Richards' book is phenomenal. He has tons of references on stuff, as well as Dr. Glazer and Dr. Morgenthau's papers as well. So I'm hoping this helps because we are clinicians, and our job is not to give a pill and say, see you in 6 months. We want to change lives. And I think we can change lives by, in my practice, we have, again, we've placed about 100,000, we have a 98% retention rate. I have a different technique when I place the pellet. I was a pelvic surgeon. Some people say place this direction. There's a space over the medius and maximus right here. My expulsion rate is less than 1%. For women, it's less than 1 in 1,000. And it's very important is to compress the area you've placed it on and ice it for a few hours. That decreases inflammation as well. So we do that well. We have a great response like that. So I think it's important that again, back to diabetes, get blood sugars optimized, get your insulin optimized. We do the same thing with these hormones that have a plethora of benefits, a plethora of every single system in our body can benefit from optimal levels of hormones. If there's any questions, I'll be honored to answer anything you have. All right. Well, I appreciate your time. Thank you very much, everybody.